Hello, everyone. Thank you so much for joining us today. We're so grateful for your participation. I just wanted to introduce myself as well as my participant. My name is Kelsea Arford. I am the founder of PAP Alliance and I am an APAP patient. And I would love to introduce Dr. Ataya. He is a pulmonary and critical care and rare disease expert at the University of Florida Health. And we're lucky enough to have him also as one of our medical advisors. So welcome, Dr. Ataya.
Thanks for having me, Kelsey.
Yes, thanks so much. Well, why don't we jump in? We wanted to have a discussion today about what it's like living with PAP and the patient journey from diagnosis to treatment. Um, so let's start first off with the beginning. Let's talk diagnosis. Dr. Taya, what do you as a or sorry, bear with me, sorry. How does a patient find a PAP specialist that can diagnose them? What do you recommend?
As patients go through this journey of symptoms and trying to figure out what they have, it can be a lonely and long journey. On
Mhm.
average, patients can end up going a year and a half before an official diagnosis can be made. And even then, that's in the cases that we actually diagnose. So once a diagnosis is made, and unfortunately, a lot of patients may end up getting biopsies, but we do have different tests available, including blood tests that's quite sensitive, specific to APAP. That then they can access, go online and get access to rare disease centers, APAP centers. And there's if you go to any of the foundation websites like PAP Alliance, other websites, there is an ability to see which centers have expertise for PAP, and then they can reach out and to those centers and see if they can get in to help in confirming the diagnosis or getting the right treatments as well, or access to trials. In your case, how did you get about in getting diagnosed?
Yeah, so as you said, it does take a minute for all of us to kind of get diagnosed. It's such a rare disease that it is difficult for us to sometimes get a diagnosis because there's so many diseases out there. I actually ended up going to my primary care provider and I was just going in for a routine checkup. And she happened to check my oxygen levels and I was sitting at 70%. With that being said, that's kind of set off an alarm, and it was like, we better figure out what's going on. I ended up going to the ER and they did a CT scan because they were under the impression that I was having a pulmonary embolism. Fortunately, it wasn't a pulmonary embolism, but that's when all the head scratching started. And it was like they could tell, they looked at my lungs, I had the ground glass opacity, and they thought, well, what the heck is this? And immediately assumed it was COVID or an inflammation type of disease. So unfortunately, I was misdiagnosed. Then was diagnosed, undiagnosed, and then re-diagnosed. So I went through kind of a struggle of that. It took about 9 months. But yeah, fortunately, I did end up getting the APAP diagnosis through the blood test. And that confirmed it. And then that started my adventure on treatment.
And that's not
Um,
uncommon. What you described is
yeah,
patients, until they hit a wall and they're in like low oxygen status or something is really obvious on CT, then people start thinking of APAP. But what
yeah,
we also see in some patients who early in the course of their disease, the symptoms are subtle. They're non-specific. They just be, look, I'm tired. I have some shortness of breath when I overexert myself. And even when you do a CT, it may not be obvious that it's APAP. And so
right.
not until the disease gets worse and your oxygen's in the 70% that, and things are more obvious and you get more formal testing. So getting diagnosed as pneumonia, asthma, etc. It's unfortunately a common story we hear from a lot of our patients.
Yeah, and I went through several pulmonologists, about eight pulmonologists, three hospitals before I finally got the answers I'm wanting. So I think it's really important for us to discuss how to get diagnosed. What are different types of diagnostic tools that you guys have available, and whatever mention do they actually give you to confirm that diagnosis?
Yeah. So it really also depends, is the patient coming to us for as the tertiary expert center for the first time, and are we doing the tests, or is it already confirmed and we are here to, reconfirm or that this is the right diagnosis? So it varies. But in general, when patients such as we use your example, are their disease has advanced to the point where the oxygen levels are low, that a CT scan or imaging of the lung is showing what these haziness in the lungs, which can look like COVID, to your point, well, how you were told, gives us this finding where all the surfactants, this abnormal buildup of lipids and proteins that are lubricant that our lungs naturally produce, it builds up excessively, and it shows up on imaging
Mhm.
when it's reaches a tipping point. And we call that sometimes
Yeah.
crazy paving, just given the pattern. Um, and that's when sometimes there's a light bulb that goes off and it's like, hey, could this be alveolar proteinosis? But unfortunately, in earlier or less aggressive disease, it may not be that obvious. So patients go through
Right.
through a lot of tests. It may be the imaging we talked about. They may get pulmonary function tests where you sit in a box and someone prompts you to
Hmm.
deep breaths. Most patients tell me that's an unpleasant experience just because you try really hard to get those breathing tests done. And that could show that your oxygen exchange or your DLCO is low. Because what happens is as you build up this surfactant lubricant in your lung, it impairs oxygen exchange. So sometimes that could be happening as disease progresses. And then, as you mentioned, we have access to a blood test called GM-CSF autoantibody. Because what happens in APAP, specifically in APAP, is our body, for unclear reasons, produces this antibody against this protein, GM-CSF. We need that GM-CSF signaling in order to have these cells in our lungs clear up build up surfactant so that
Right.
new one comes in. And once we inhibit it, these cells don't do their jobs, and the surfactant builds up. Symptoms develop. We said we can get this antibody test through the University of Cincinnati. They have a lab that runs this test, and we also have now commercially available tests to do it as well. So there are now more opportunities for patients to get this blood test. However,
Yeah.
up to this time, a lot of patients end up getting a lung biopsy, so there was a good study many years ago. It shows a lot of patients end up getting biopsies and not the blood test because, awareness was a problem, access to the test was a problem, and that's changed over time. And sometimes when your
Right.
physician does a bronchoscopy, they can see all this buildup protein in the lung. All that can
Exactly.
help us reach a diagnosis in a way in the patient. We want to
Yeah.
avoid biopsies, right? So, if
Exactly.
to,
That's the key. Is there's far too many people I know that have had the biopsy, which did lead into the diagnosis that they got. But yes, fortunately for me, I actually chose not to do a lung biopsy because I'd gone through all this and I thought there's got to be an easier way to figure this out. And I was very fortunate to find out about the blood test, and that was the, saving grace for me. So now that we know how to get diagnosed and we have all those options out there, what about treatment options? Can you kind of walk us through what kind of different treatment options are available?
well, when we officially make a diagnosis or reconfirm the diagnosis to the antibody test, we sit down with our patients and we try to determine how sick they are, right? I think that's one of
Hmm.
the most important first steps in when we discuss severity of illness. If we have patients with mild symptoms and on the other end of the spectrum, a patient in respiratory distress, high oxygen needs, has to come in through the ER, our approach to treatment will be very different depending on where we meet them in their patient journey. And the
Okay.
reason that's important is, when we talk about treatments, one of the things that keeps coming up is whole lung lavage. And
Yes.
by the way, have you had the experience of going through a whole lung lavage?
Yes, I have had a whole lung lavage. Fortunately, I've had one, and that's it. So I've been a very, very lucky person, but I know that there's people that have had 30, 40, 50. And that has to be detrimental for them and just the time and the pain they go through for a whole lung lavage.
And everybody's approach when we our first thought when we talk about whole lung lavage is that this is a very difficult procedure to personally go through. There's a heavy
Yeah.
burden. What's your take on it as a patient who's actually gone through it?
Yes, absolutely. So when I finally was diagnosed and then I was told about the treatment options that were available, the whole lung lavage was the only option that was available. So you kind of were like, well, I guess that's what we're going to do. So I was had the opportunity. Fortunately, I had two pulmonologists tell me how whole lung lavage is done and whatnot, but you don't really know until you're in it. And so I knew what to expect. I did watch a YouTube video just to kind of get a gist of it, which was a little bit informative, but it was kind of like, not, I'll be sleep through this, so I don't know. But yeah, it is very the expectation I had and then the aftermath were totally different. I thought it was going to kind of be a breeze. I was like, oh, you just go in, they clean you out, you're good. I ended up having 27 liters on both sides. And it was a 2 day period, so one lung per day, and it was 6 to 8 hours per lung. So that really did take me out. I mean, I felt like I got hit by a Mack truck after that, and just the throats with all the tubes and everything. It was definitely not my favorite situation, but
And
unfortunately, that's
yeah,
all you get.
and that's part of the reason why we also reserve this whole lung lavage procedure for our sickest patient, for two reasons. One,
Right.
it is an invasive procedure, and we'll talk about the details about it. But two
Yeah.
is to actually see risk benefit, to see the true benefit, you have to have enough burden of disease. So if we perform a whole lung lavage in someone with mild to moderate disease, we may put them through all that invasive procedure and everything that comes with it, and we may not see that big of a difference because there hasn't been enough buildup of surfactant in the lung. And that's why it's so important to reserve this procedure. Usually, most centers reserve it for more severe cases in that severe APAP situation. And to your
Yes.
point, it requires going on life support with a mechanical ventilator, OR ICU bed. You're out, you're
Yes.
paralyzed, you're sedated, you have a massive breathing tube that makes you sore for days. And like you probably put it, you feel like you've been hit by a truck. It works. You literally
Yeah.
go in and take your lungs to the car wash. We clear out one lung at a time, massive amounts of fluid. We literally drown and wash them out. But the idea
Right.
is we cleaned up that excessive buildup of surfactant. So now oxygen can pass through to the blood. Now patients feel better, but we don't
Right.
fix the underlying problem. And as you mentioned,
Exactly.
some patients will need another lavage because the antibody's still there, the disease process is there. And that's why that's one of the available treatments. And then one of the other limitations, not every center will have access or the expertise to do a proper whole lung lavage. And that's another aspect as well.
Exactly. And I think I mean, you kind of already touched on it. So, the factors on deciding the recommended treatment, you kind of touched on it. It's based on severity. Is that kind of how you guys base that?
Yeah, so when you're in respiratory distress, your oxygen levels are in the 70s,
Right.
you need oxygen, and which is one of the treatments here. Obviously, if your oxygen levels are low, we need to supplement them. The nice thing is some patients may come off oxygen after a whole lung lavage or with adequate therapy we'll talk about, but that's part of the treatment. We need to determine where in the journey they are so we can, personalize the therapy to them. But unfortunately,
Right.
we don't have many options of therapy. One of the big things we do for our patients is we consider enrolling them in clinical trials. So we had the Impala 1, 2, 1, and then the Impala 2 trials for
Right.
molgramostim that just finished. And we may try off-label therapy with GM-CSF, but with a lot of difficulty with insurances. It's now that therapy is also available in Japan. Hopefully, it will be available in the US as well in the near future. And then enroll them
Yeah.
in early access programs as considered part of the study as well nowadays before we get hopefully approval of the drug. And there
Right.
are also experimental therapies. We try immunosuppression with drugs like rituximab, therapies like statins, etc. And in our most severe cases, patients who, despite off-label treatments, lavages, we sometimes reserve a lung transplantation for those patients. And that is, despite being a small percentage of our patients, is a significant jump or leap in therapy for the people with
Right.
the most advanced of disease.
Yes. Yes. I can't even imagine. I just, oh. Well, in regards to that, what advice would you give to a patient on navigating treatment options? Like, how would you encourage them to approach their physician, and determine their treatment plans with their physician?
I think for every patient, it's so important to be well informed. Important for them, especially when living with a rare disease. We call them orphan lung diseases for a reason, because
Right.
people feel that they're out there on their own. It's hard to find a community of patients and providers and that, share information with. So patients are their own advocates. So I encourage always all our patients to go out there and figure out where are the centers that see the
Yeah.
most patients, the centers of excellence for APAP and other rare diseases, because these diseases are rare enough to the point that many physicians may not routinely come across them, and they tend to be centered around these larger centers and that's where the expertise is, and the access to clinical trials and different programs. So encourage patients to do their own research, find the centers that are closest to them with expertise, and reach out, even if it's across state lines, or sometimes I get calls from different countries. Reach out, send an email, see if what advice you can get and what's availability of trials or off-label therapies. There's a lot we
Yeah.
can offer to our patients.
Thank you for that. I think that's so important. And you know what? It looks like we have a question from the audience that we'd like to ask. Let me see if I can find it. Bear with me just a moment. I'm so sorry. All right. Lily's going to ask. Oh, I apologize. There is no question, but please, for any participants, if you have any questions, please put it in the Q&A at the bottom of the screen, and we'll be happy to follow up at the end of the webinar and discuss it with you. And so let me
And
ask you.
Kelsey,
Oh, go ahead.
yeah,
Sorry. Please go
no,
ahead.
it's okay. One question I always get from patients is nowadays, what is there available? And one of the things that comes up, I mentioned earlier, this early access program, or EAP. Um,
Yes.
and this is sometimes I think, as patients are struggling to figure out, well, if there's no trials currently open and there's no off-label therapies, or access to off-label therapies is difficult, there is currently an early access program. It's by Savara for molgramostim. And what it is patients can enroll like any trial, go to
Right.
these centers, there's selected centers around the country in the United States that have access to this program, and can, if they meet criteria, having APAP, diagnosed, severity, etc., they can actually be enrolled in this early access program to get access to the drug inhaled therapy in order to see if they can benefit based on the results of the recent trial results. We know that drug seems to work based on this data. So
Right.
and to order to find out which centers actually have these early access programs, you can post on the clinical trials website. I can ask the team to put it online. These are programs they can reach out and say, "Hey, I'm an APAP patient. Could I be considered for this early access program?"
Yeah, and I think it's so important for everyone to look into the EAP programs because that really is going to help us benefit from hopefully, having an opportunity to have a drug that's related directly to our disease. Um, so I think a lot of us run into this. I know that I ran into this as a patient, insurance. That seems to be a really big issue with us. And so, what would you recommend in navigating insurance and getting access to the treatment? And, like I'm sure you've heard from your patients and you've experienced it yourself. What are some of the more stressful parts of the experience with insurance?
Unfortunately, the way our healthcare system here in the US is set up, it's part of our everyday life that it's something that we have to deal with. And, centers that have had experience treating rare diseases have a team that is dedicated to managing and supporting patients through this difficulty of insurance denials, appeals, etc. And the larger challenge here for patients with APAP is currently there is no FDA approved therapy for APAP. And that's where the
Right,
real struggle lands, because we do have on the market off-label GM-CSF. And the the challenge that I run into and other centers run into too is we try to get most of our APAP patients on that therapy.
right,
Unfortunately, we get, denied by insurance because it's not FDA approved and it's not standardized. And these are things that, unfortunately, despite our best intentions, cannot get patients on therapy. Now,
right,
that is a challenge because there's no off-label, it's off-label, there's not the approved treatment. obviously, once we have FDA approval for therapy, that process is much easier. Doesn't mean it's going to
Right.
go away, right? We still have to deal with insurance. We're still probably going to get denials that we can at least appeal because we have the an FDA approval. But it's just something that I tell all my patients, like work with your doctors, work with their teams, and be patient. It takes a
Yeah.
long time sometimes to get an approval, but it's something that, especially once we have an FDA stamp of approval on it, is probably easier hurdle to overcome.
Yes, and I think that's one of the big things that a lot of us are looking forward to and hoping for that that will be an opportunity for us because I know in my own experience I did have difficulty getting my insurance to approve it because it was off-label. And so they ask a lot of questions, and I understand that it is obviously an expensive drug, but again, I always feel like it's better for us to have an opportunity to have some treatment so that we can have more opportunity between lung lavages, because those are definitely the most intrusive treatments that we have, unfortunately. I know that I had an opportunity where my physician, my doctor actually wrote a letter to the insurance company explaining the need for the off-label drug for us. And that was kind of, I think, what was the slam dunk for me that got them to process it and agree to it. So, yeah, there's definitely thank you for letting us know about the resources and opportunities for us out there. Um, well, it looks like we have a question from the audience. And so if you don't mind, we're just going to pivot over
Yeah,
there. So we have a question. So we have a patient who says, even though I've gotten better over 4 months after using the molgramostim, is it still normal to be tired more than before having APAP?
yeah. So, fatigue is a real part of this disease illness, right?
Yeah,
Regardless of your oxygen levels, we've seen people with normal oxygen levels and they're absolutely tired because this is an autoimmune disease. So there's probably aspects to it that affect fatigue and your energy as well. Now,
right,
molgramostim or any form of inhaled GM-CSF, it takes a while to work. These because the way these drugs work, they bind these antibodies in your system so that they actually GM-CSF can do its job. These cells can now clear up that surfactant, but that process takes a while. The trials showed that maybe up to 12 weeks before we start seeing a decent improvement in
right,
DLCO and patient symptoms over time. What we know from real world experience and what we know from the clinical trials that went on to 24, 48 weeks plus is the longer you are on therapy, the more benefit you have because that process of clearing up that old surfactant takes time. So
yes,
as you're on molgramostim, it seems like 4 months. We're just starting to see, depending on how much of a burden of illness you've had in your lungs, we start seeing things start starting to separate. So what I
right,
would recommend is one, be patient, give it more time, especially if we're seeing improvements. For example, we'll notice oxygen levels are slightly improving at this point. Maybe the DLCO on the breathing test is starting to show improvement. We're moving in the right direction. And,
right,
these are, and more importantly as well, we have to also look, is something else going on? What happens is with rare diseases is we tend to anchor as patients, as providers on the rare disease, and we keep forgetting that common things are common. Has
yeah,
your provider during this time looked at, are you iron deficient, vitamin D deficient? Is your thyroid okay? Is there an superimposed pneumonia, etc.? So we want to make sure we don't miss the obvious while also giving time for the drug to work. And then if despite these factors and there's still no improvement, coming back to the drawing board, what's going on? Do we need higher
right.
doses of GM-CSF, or is the disease at the point where you actually would benefit more from a whole lung lavage and then getting the GM-CSF on board? So these are questions and challenges that patients may encounter, and probably talking to your provider is important to see where you are in your journey with APAP and what else is going on. I hope that helps answer
Ex
the question as well.
Yeah, I think that for me, which I can relate to this patient is, yeah, the fatigue would knock me out, and I still have fatigue and brain fog. I feel like half the time I'm like, what was I thinking about? But yeah, the fatigue definitely knocks me out, even at my best oxygen level and my lowest oxygen level. That was one of the key symptoms that I definitely can relate to. So let me ask you. Can you give us a little more details on the sourgramostim that is approved in Japan? Just a little more details on that. And is there a way for patients in other countries that they can access that?
So, off-label GM sargramostim, which is the off-label GM setup version as well, is available in the US, but obviously it's all off-label, and that's where the chance I talk about
Correct.
getting insurance approval. It is extracted in a different way to molgramostim, once from a bacteria, once from a yeast, but the
Right.
goal is the same. The GM-CSF will bind the antibodies so that the body's regular functions can return to normal to clean up the surface. The challenge, I can't speak to Japan. I'm sure they have a standardized way, but the challenge, at least we
Right.
encounter, is we approve this medication, which is an injection off label, but then it is not made to be nebulized because that's how we give this therapy, right? In the past, we used
Right.
to inject it, but we found out it doesn't work
Hmm.
as well compared to inhaled. But even when it's inhaled, we would have to ask our patients to dilute it with sterile saline, put it in a regular nebulizer and then nebulize it, and then that doesn't take into account how much wasted drug there is. So
Right.
there, and every center would do it different. Every center would dilute it differently. So people have even different ways of using off-label therapy. So that's the challenge. It's not standardized. So for patients, I'll talk to your physicians if that's an option, if they can get it, but outside as an off-label therapy. In other countries as well, seek expert centers. There's many in Europe, there's in Germany, there's in Dublin, in England,
Right.
and of course in Japan. It's probably, I think, the only country that has it approved by the regulatory
Great.
agency. And hopefully in the near future, we will have an FDA approved treatment here too. Fingers crossed.
Yes. Yes. Fingers crossed. We're all hoping for that. So it looks like we have another question from the audience. So we have a patient who says, I find it overwhelming to try to manage my care. What are your tips for coordinating my care?
That's an excellent question. As you're dealing with what you consider a chronic disease and a rare disease, it becomes very overwhelming, especially when you're first diagnosed. Where do I go? Who do I talk to? What I'm going to do? Who's going to help me with my oxygen? How I'm going to figure out this insurance problem? Everything you've been talking about. Where can I see clinical trial help? It's hard, and finding a
It is.
community is important. And this is not just for APAP, for all rare diseases. It's finding your people, right? Finding people who
Yep.
only not because as I mentioned, you feel orphaned in this illness, but finding people who've gone through this, who've had experience. As physicians, we have all best intentions, but we don't walk in your shoes. We've never experienced this disease. We know everything about it.
Yeah.
So patients who've been dealt with this for a while, who are on GM-CSF on oxygen, and there's a lot of communities, PAP Alliance, other foundations like PAP Foundation, and there's also
Right.
ATS. There's so many out there. The Facebook groups are great too. Find the people who've been living with this, talk to them, connect with them, learn from them. And that is one of my top advices. Find a community, and the PAP community is always welcoming.
Yes, no, and I thank you so much for that. Yeah, and that's a big reason why I started PAP Alliance. I felt very like isolated because I went from like having a normal life existence to overnight everything in my life changed. And I came home with a tank of oxygen and an oxygen machine to keep me going the whole time. And it really was detrimental to my mental health. I mean, I definitely let my mental health go out the back door because I was so focused on finding a diagnosis and finding a treatment so that I could get back to normal, is what I thought in my head. Little did I know, I definitely have a new normal now. But yeah, PAP Alliance for me was finding that community. As I say, find your village is what I say to people. Find your village, find your people, find your, people that can relate to it, but also get that support that you need because again, I let my mental health really go by the wayside, and that's something I really regret. And I wish that I had put more focus on that while I was also going through this physical treatment as well, because I think you have to be mentally prepared so that you can physically prepare yourself for what you need. But yeah, I think that's definitely a big part of it, community.
And there's
Um,
multiple layers for this, right? You mentioned hit the nail on the head. We focus so much on the physical part, but there's that mental part
yes,
as well. People have anxiety, PTSD from whole lung lavage, seeking care. So find a community, find expert physicians, or even if you're
right.
nowhere near one, reach out. We are very accommodating. We will reach out, call. We have centers up in Cincinnati, in
Yeah,
UCLA, National Jewish here in Florida. We try to cover the quarters, but there's experts there, and we are more than happy to touch base with patients who need help and help, point them in the right direction if they're not near us as well.
exactly. That's the key is getting you the right resources and pointing you in the right direction is key. And I thankfully was lucky enough that I live in a very large community that has that. But yeah, there's not everyone's as lucky. And so it looks like we actually have another question from the audience. And this person asks, do you know of any new reports or journals that have a clue on the cause of the autoimmune lung disease?
So there's so many autoimmune diseases out there, and unfortunately, we don't know why some individuals may develop autoimmune diseases while others don't. Obviously, there
Hmm.
are genetic factors. When you think of diseases like lupus, rheumatoid arthritis, they tend to run in families, autoimmune diabetes, while others don't.
Right,
So, and there's this, the genetic factor, there's the environmental factor. So we don't, for each autoimmune disease, there might be variable reasons and unclear reasons why it develops. But in APAP specifically, we don't know why some individuals go on to develop autoantibodies to GM-CSF, where they come
hmm,
from and why they happen. So obviously it's an area of active research, but at this time, it's unclear why certain individuals get APAP while others don't. We do see some normal individuals out there. It's a very small percentage that have very low levels of circulating GM-CSF antibodies and
right,
that don't have APAP, but like we don't know why that happens. And GM-CSF, while we talk a lot how this antibody predisposes to APAP, we also have to consider that it also predisposes you to these what we call opportunistic infections in the lungs. You can get these odd
right,
infections most people won't get. And the reason for that is it affects some of the cells in the lung that fight off infection. So, and that is what sometimes drives complications in some APAP patients too. And these are things that patients struggle with. And, this is an area of active research to figure out why these autoimmune disease, specifically in APAP as well.
right. Yeah, I think everyone that's probably had this disease has had the opportunistic infections that it's like a constant rolling thing. You have the APAP, but then you also get these other fun things that come with
Yeah.
it. So yeah, the joy of that. We have another question too. So by any chance, have you heard of anybody that got rid of the PAP? So I'm guessing remission is kind of what they're asking in regards to.
There's two ways to answer that question. We do have, every now and then, we may see an APAP patient with antibodies where their
Hmm.
disease in the lung may regress on its own. So we have not done GM-CSF therapy. They may or may not have had whole lung lavage in the past, but their disease kind of regresses in the lung. We don't see as much, doesn't progress. They still have the antibodies, but we don't
Right,
have the lung involvement anymore. And we're not sure why this spontaneous, what we call spontaneous remission occurs, right?
right,
Perhaps they were smoking and they quit smoking, or they were taking something that was aggravating their illness, or they took something that improved their illness. One theory is potentially statins as well. We don't know.
right,
And then there's another form, which is even more exceptionally rare. I think I've only encountered one case where the patient's body stops producing the antibody. So not only does the lungs get better, but when we check for the autoimmune antibodies, they're no longer there. I think I've personally seen one case. We don't know why, but that again is exceptionally rare. So when you're in this question, and what we usually think when we talk about spontaneous remission, you still have the antibody, just the lung disease it doesn't involve. That still remains on. Good advice is
and
always don't smoke and stay active, right? And wear your seatbelt. All right.
yes, exactly, exactly. Very good advice. That's interesting. So So it looks like we have another question. Oh, it's for me. So I was recently diagnosed. Kelsey, what do you wish you knew when you were first diagnosed, and any advice? Um, so welcome to the village. So that you're newly diagnosed, so you're welcome. I definitely think that what I wish I had known when I first got diagnosed is had a tendency to kind of lead in to just the physicians that were treating me and just, going along with it. And what I wish I had known is advocate for yourself. That was a big thing that I had to learn very early on, which did lead to me saying, no, I'm not going to get a lung biopsy. So that was a big advocate for me to advocate. But advocate for yourself. Find people that you can relate to. That doesn't mean that you have to have the same lung disease. It doesn't mean that you have to even know what you have, but you have a lung condition. Do research, look around, ask your physician. Make sure that you have people that they're there to help and support you. That's a big one because you kind of have to take a time out from life. In my case, like I said, I literally overnight, I went from just a normal person to like completely almost like a prisoner in my own home because I was on oxygen therapy. That was the only treatment I was getting. And find people that can help you. That's the one thing I really wish that I had seeked out early on. And then more importantly, advocate for yourself, stand up for yourself, ask questions. So what do you, I mean, I guess I could pivot that to you too. What are there some exceptional patients that you've had that you're just like, they were a rock star and this is something they did really well, and I 10 out of 10 recommend they do it?
I I'm very lucky that a lot of my APAP patients are all phenomenal, but I can tell you that some are exceptional good advocates. They've dealt with this for a very, very long time, had to
Right.
seek their own diagnosis, and this was back like maybe in the 90s. So the best patients are those who remain positive, who advocate for themselves, who work with their teams and their doctors. And
Yeah.
if you don't feel that where you are, you're getting the right care, you're not hurting anyone's feelings. Seek another opinion. You're not hurting
Agree.
anyone. We all want the same thing. We want you to be the best version of you, to be healthy. And if it involves getting other providers involved, that's what we're here for. We want to advance the field and help patients. And the way we could do it is by working together.
That's awesome. That's so comforting to hear because yeah, I definitely was a little weary in the beginning. I did seek a second opinion and I unfortunately got a third opinion. So yeah, I definitely think if you don't feel like you're getting the care that you need or they're not answering the questions that you need, it's not harmful to seek out another physician to help you with this because it's diagnosis journey can be really rough.
Yeah.
And so,
I mean, currently I'm working with a team out of Colombia. They have a patient, and
right.
the unfortunate part is like, what do we do? There's no access to care, there's no clinical trials, there's no EAP. So we're very fortunate here, and our hope is, with as a first step, FDA approval, European approval, international approval, we can help patients not just here in the US, but internationally who are living with this disease. It's much more common than we think. Just
It
getting the
is.
diagnosis is the hard part.
Yeah, and that's a huge part of another reason why I wanted to get PAP Alliance up and running is because I really wanted us to come together as the entire world, not just your backyard. Because there are so few of us, but like you said, like it's really not that uncommon. It's just making sure you're getting diagnosed appropriately, and that's kind of what we're having some issues with is trying to get everyone diagnosed. So.
Yeah.
We have another question. So I was diagnosed in 2018 with a surgical lung biopsy and the blood test. My condition has been stable with no change since 2019. I believe it was because I was controlling my cholesterol. Is there any evidence to support cholesterol reduction as helping to stabilize PAP?
Yeah. So there's a great reports coming out of University of Cincinnati that showed that patients that went on a cholesterol medication, a statin, they actually had improvement in their APAP. I tend to
Right,
give it to my patients too, for a similar reason. The idea is the cholesterol medication, the statin, what is Norvastatin, Simvastatin, etc., can help these same cells, the clean up surfactant, the macrophages,
right.
recover their function in a different way by removing this excess cholesterol that builds up in them so they can actually clean up surfactant. Obviously, this is only based on very, very small studies. This is not a big trial. This is not the standard of care. But this is also a low-hanging fruit that sometimes, in the absence of any available treatments, might be an option to consider that's safe for some patients, perhaps. Um, but yes, there needs to be more research into drugs like statins. There's another drug
Agreed.
like called pioglitazone, and there that is being studied that may do something similar. And but again, weak evidence, but there might be something to it. So, as long as it's safe and if there's no other treatments, we may discuss it with our patients to see if that's an option.
Yeah, and that's what my pulmonologist can't hurt, might help. It's kind of his
That
analogy.
kind of,
So,
but doesn't replace the need for whole lung lavage. And I want to also clear up for patients that
right,
if you're that sick, your oxygen levels are low, and that you're in respiratory distress, a whole lung lavage will give you immediate relief. But these other therapies, maybe they'd work off label, but they take a while to work too, because you're not immediately removing that excessive burden of surfactant from the lung.
yeah, and just touch on that. Just there's definitely some myths versus facts that we have. So I kind of want to debunk some of these if we could. Since you say that that doesn't replace the need for a whole lung lavage, is it true that everyone with PAP would eventually need a whole lung lavage?
No, that's not necessarily true because I've
Okay,
seen patients who've never had a whole lung lavage, right?
agree.
Uh, but most patients may require one or two whole lung lavages across their lifetime. Remember, there's something that's not in the literature that we talk about is even among patients with the same level of antibodies and titers in their blood, some may accumulate surfactant faster or slower compared to others, and that we don't know
Right,
why. We call them fast accumulators, rapid accumulators, or slow accumulators. And we're not sure what environmental factors, genetic factors may play a role.
right,
And so if you have someone who's a fast accumulator of surfactant, those are the patients that you mentioned who have had multiple 10, 20 plus whole lung lavages because they accumulate so fast despite other therapies. And others who are
right,
very slow accumulators that we haven't maybe followed them long enough, but have never required a lavage or just needed one, and they accumulate so slow that it's been years since their last lavage. I have a patient who her last lung lavage was probably the 1980s, and
oh wow,
she hasn't had one since. Uh, but every day patient is different.
that's amazing. That's wonderful to hear that. Obviously, there's different levels. We all one thing in common. We have the disease, but we all kind of accumulate, and it affects us each differently. But um, in regards to that, to symptoms, do you think that the symptoms reflect the severity of the disease, or can it be different based on different people?
I mean, it's not one glove fits all, but generally we see that the as the surfactant builds up in the lungs and we have more lung involvement, we tend to see lower oxygen as the DLCO, that test we do on the breathing PFTs, gets lower. And that seems
Right,
to correlate pretty well with patient symptoms. Because obviously, as you have more burden and you can't breathe as well, and your oxygen is lower, you get to be more symptomatic. And the same in the opposite direction. If you get good treatment and you remove that surfactant, your oxygen exchange improves, you tend to feel better. But there are these
right,
caveats. Someone mentioned fatigue, which may be independent, right? Infections, which could be independent, lung scarring, or what we call fibrosis, which is rare, but that also could
exactly.
be different factors. But generally, yes, they tend to correlate with symptoms. What I could tell you is the antibody titer levels don't necessarily correlate with disease one-to-one with disease severity and symptoms. It's there, we see it, and there's different tests we can do on it. But yes, it tends the disease severity, as we see on CT and DLCO, can correlate with the symptoms that patients feel and their walk, exertional.
Yeah, yeah, exactly. So you kind of touched on this a little bit. We were talking about pulmonary fibrosis. So we have a question. Can APAP develop into pulmonary fibrosis, or is that an additional diagnosis?
Um, so pulmonary fibrosis is when there is scarring in the lungs, that the lung tissue itself gets scarred. Now, when we think about APAP, pure APAP on its own, the
Hmm.
underlying lung under all that excessive surfactant is normal. So that's why the
Right.
idea is if you remove all that surfactant, your lungs are normal, they can exchange oxygen, and that's a very, very unusual thing about this disease entity compared to other lung diseases. However, in a very small percentage of patients, we believe less than 10% of APAP patients do go on to develop pulmonary fibrosis or scarring. And we are unsure why. It could be there's different theories out there. One is, well, could it be due to repeated whole lung lavages? Yet you could
Hmm.
have patients who've only had one and still develop scarring. So that maybe that's not it. Could it be the opportunistic infections? They've developed infections over time. And again, some patients never get those opportunistic infections and end up with fibrosis. And third is it a spectrum, a rare complication of the disease itself? And, people eventually, due to a second hit that we don't know about, scarring kicks in. And
Right.
unfortunately, that scarring is where some patients who develop it run into trouble because it's no longer GM-CSF therapy doesn't work for them. These whole lung lavage may not give them that benefit because it's not surfactant, it's the lung tissue itself that's kind of changed. And these, in the situations when we discuss lung transplant, usually happens in people who actually develop pulmonary fibrosis.
Okay, well that's good to know. Yeah, I have heard about the pulmonary fibrosis connection with APAP, and so it's interesting that it's 10%, which is still small, but still, that's a good chunk. So, all right, well, let's get through a couple more questions. I'm so excited that everyone's ready to chat. So I've heard this before, and I'm actually interested in this as well. Have you found that a certain diet improves the health of PAP patients? I've heard there's a lot of autoimmune diets, and I don't know if that's myth or
I,
fact.
I don't know. I haven't seen any clear diet that helps, but what I would tell my patients is eat healthy, healthy lifestyle, healthy diet, and enjoy the things you want to enjoy in life when you can. But like nothing clear that I've seen that correlates with disease severity as well.
Right.
Do not go
Okay.
on an unhealthy diet just to get a statin. Let me just put that out there. But
Don't
other
start
than that,
eating fast food just to get on a statin. Exactly. Good call. I think that's in the long run, you don't want to be on a poor diet. Okay, good. Well, that's great to know. So we have another question. What are the best ways to get the message out about this disease to help raise awareness and to ultimately help get more people diagnosed and help relieve their struggles? I'd like to answer this too, but
yeah,
you go
please.
right ahead.
I was gonna say,
Uh,
reach out to Kelsey. Yeah.
yeah, exactly. Perfect answer. I was going to suggest you say that. Yeah, definitely. I strongly suggest that you reach out to the PAP Alliance. We have wonderful resources for you guys. We really are also looking, you guys, as patients, caregivers, physicians, the whole community, you also are such a huge part of getting the word out there too. So a lot of it is just connecting with people within the community and be able to share that information and get it out there. And I think that that's a large part of it. So, what about you, Dr. Taya? You have any anyone you want to prop up or give attention to?
Yeah, I would say, go online, find in any other social platform you can find patients living with your illness, find societies that promote want to help patients, be
Yeah,
involved. I think what I see with a lot of patient organizations for diseases is these fundraisers, etc., to,
yeah,
you know, and awareness campaigns, and those are what's important. And and reach out to these different centers wherever you are in the world. I could definitely drop my email in the chat for anyone who's interested. Reach out. If you have questions, you need help, just want advice.
right.
We us and I know my colleagues in the other centers of Access for APAP are more than happy to assist and to at least provide uh, advice where we can.
Absolutely. Yeah. And one big thing for patients and caregivers, we also encourage you to share your story with us. We have blogs and we also will post them on the website. So that I think helps build the community. You get a better feeling of what other people are going through and how you can relate. And I also offer support groups every other month. So we will be having a support group in March. So you are all invited. Um, And then lastly, let's get another question here. So it looks like it's directed for me. Hi, Kelsey. Are you connected with PAP patients and organizations in Europe and which ones? And thank you, Andrea. She wants to help. Listening to us, she wants to get involved and help. First off, Andrea, please email me, kelsey@papalliance.org. We will definitely be in contact. And yes, I do work with some other organizations. I'm involved with EU PFF, pulmonary fibrosis. And so I work with them. I will actually be visiting them. They're having their seminar in May, so I'll be joining them out there in Brussels. So you're welcome to join us if you want. And I also have a lot of connection with some patients in the UK right now. I've talked to a few in Greece, and I also have some in Chile as well that I've been in contact with. But yeah, I do have also two medical advisors, Dr. Cormac McCarthy, he's in Ireland, and Dr. Kokosi, she's in Britain. So yes, I'm involved with a lot of people. So please email me and we can connect. Oh, yes. And my email again, sorry, Kelsey. So it's KELSEA at papalliance.org. We'll put it in the chat too. You can also go to papalliance.org and you can connect with me there as well. And so, all right. And see, Dr. Ataya, he added his email. Thank you for that. We appreciate that. And then lastly, let's just finish up a few things. I think that we're getting close to the end. So what is one takeaway you want patients to leave this conversation with?
Um, there's hope. I think a lot of patients feel scared. They, especially with a new diagnosis or an opportunistic infection and finding out for the first time, a lot of patients are actually scared about being on oxygen, needing a whole lung lavage. And I would like to say, by as we repeated over and over, talking to people who've gone through this, reaching out to the
Yeah,
centers, and we are at a period where we may are very close to an FDA approved drug because the trials were so positive that I'm really hopeful that we have more to offer than just whole lung lavage and off-label therapy, that we can have
yeah.
treatment that can have sustained benefit for patients over time, get them off oxygen, get them feeling better, and get their quality of life better. So there's hope.
That's so great to hear. I agree with you. I think one takeaway that I think I want everyone to understand is you're not alone. First and foremost, you're not alone. We're out here. There's a community, there's a village. But more importantly, and I think that I had to remind myself of this, life gets better. This isn't forever. It gets better. You learn to adapt your life around your disease rather than your disease adapting itself around you. You get to control this. And so it's different, but it actually is better. If it weren't for this disease, as much as I don't love that I have it, I wouldn't have been able to meet all these beautiful, wonderful people like you, Dr. Ataya, and all these other patients and caregivers and just the whole community. And so I'm very grateful that I've had the opportunity to spend this time with you today, but more importantly, just for the rest of their future and what we have. In regards to the future, big loaded question. What gives you hope about the future of PAP care?
Um, I think, you know, the how much has changed over the last several years. When I started practicing and taking care of APAP patients, we had, it was hard getting testing. And then,
Yeah,
obviously we started connecting with other centers and collaborating. And then we were doing testing like the University of Cincinnati. And then next thing, we were initially doing GM-CSF as an injection. And then
yeah,
we transitioned to it. Now we're using nebulized. And what I'm trying to get is a lot has evolved, just the
right.
way we were approaching it. There's now guidelines out of Europe. Hopefully, we'll have guidelines out of the US. We're on the verge of an FDA approved trial. So I think as we grow and we shed awareness on this disease, I think the entire disease space has evolved, and we are at the point where things are really changing at a much faster pace. And we have so much more to be able to offer to our patients.
I agree with you. Yeah, even for me, I got sick in 2021. So now I'm on my 5 year anniversary. And from when I got sick to now, it's night and day. I mean, when I first started researching, trying to figure out what was going on with me, I mean, there's, I think, 3 or 4 articles out there. And now, I mean, there's just you Google, pulmonary alveolar proteinosis, and you get lots of hits, which is amazing. So, that's so great. So, well, thank you so much for your time today. I cannot thank you enough. I know you're a busy man, and we are so appreciative of your time and your presence and everything that you do for us as patients and everything that we have in our day to day. So appreciate you so much, and we hope to meet again.
Thank you. And thanks for everybody
Yes,
for joining. And I really appreciate this opportunity.
wonderful. All right, gang. Well, thanks so much. Please reach out. Both of us have put our emails in there. You can also go to the papalliance.org for more information. And we look forward to another webinar in the future.
Thank you.
Thank you. Bye bye, everyone. Have a wonderful day.